as you guys know, we take our role here at Families in Service to you very seriously. And so this next panel, we hope, is a really big help to all of you. Now we get to hear directly from true leaders in philanthropy about their view of this, how they're thinking about the role of value in their work and in the way they support all of us. So each of our folks here on the panel play a pivotal role in the strategic direction of their philanthropy, and each is an expert in the many facets of the conundrum that is healthcare value. They've had very distinguished careers, and their full bios are available on the Health Action app. First, we have Ann Weiss. Ann is a managing director at Robert Wood Johnson Foundation. She's at the helm of the foundation's efforts to build a culture of health through the work of transformation. Ann joined the foundation in 1991 after a distinguished career in healthcare policy at both the federal and state level. She served in a senior leadership role in state government, the Senate staff at HHS, and the White House Office of Manage and Budget. Welcome, Ann. Next, we have Timothy Lash. Tim is the Chief Strategy Officer and Executive Vice President at West Health. He also serves as the President of West Health Policy Center and President of Gary and Mary West PACE. Tim has extensive experience in shaping and advancing innovative and disruptive healthcare models. He's also been a very successful leader in establishing collaborations across diverse groups of stakeholders and organizations and creating new growth platforms. Prior to joining West Health, Tim held a leadership role at J&J and several other healthcare companies. Welcome, Tim. And then finally, we are thrilled to have Cara Carter, who is Senior Vice President of Strategy and Programs at the California Healthcare Foundation. Among her many responsibilities, Cara leads strategic operational activities at the foundation. Cara oversees the team's work that is working to transform Medi-Cal, the largest state Medicaid program in the nation, to better serve Californians with low incomes. Cara also helps to lead CHCF's work around improving care for populations with high needs and high cost. That includes people with mental health conditions, substance use problems, and other complex problems. Prior to joining CHCF, Cara was a partner at McKinsey & Company San Francisco office, where she helped public sector health and social service systems in the UK, the US, and globally to improve quality of care while ensuring affordability and broad access. Welcome, Cara. Okay, so for this session, we're going to use the same system. So please, guys, lift your hands up if you have any questions at all. These are the leaders of philanthropy. You got to have questions. I'm sure you do. So please, let's get them going. We have an opening question for everyone. The first is, each of your organizations exist to improve the health of our nation. Each of your organizations also commits very significant resources towards addressing healthcare value and transforming the way in which care is provided. Can each of you spend 2 or 3 minutes explaining why you see transformation and value as so important to fulfilling your mission and how you are investing your resources in these efforts? Who would like to start?
I'll start. I'm
terrific.
On the left. So with the Robert Wood Johnson Foundation, we are working with others to build a culture of health, which simply means a society in which everyone has a fair and just opportunity to lead a healthy life, because that opportunity is really at the core of health equity, something we're going to be talking about today. I think Governor Kitzhaber and our panelists, very more eloquently than I ever could, reminded us that that opportunity to lead a healthy life is not something that the healthcare system alone can give us. But it is true, and everyone in this room knows it, that the affordability of healthcare is a major barrier to families having that healthy life that we all want. Spending on healthcare, premiums and coinsurance and deductibles and uncovered services is crowding out spending on housing, on childcare, on food, on all the other basic necessities of life, and it's creating financial instability, emotional stress, and driving families into bankruptcy. At the same time, I think we hear from the previous panel, that a lot of the transformation, a lot of the things going on to tackle that problem are being driven by very powerful market forces and policy and political forces. So when you ask what our foundation is doing, this is not something where philanthropy is in the driver's seat alone, So how we try to think about it is, where is the intersection between these efforts to reduce costs and improve outcomes and value, and what it will take to help people lead healthier lives in our communities, to create the conditions for health. And this takes us to 3 places. The first is working with the healthcare system to help it do a better job identifying and meeting the health-related but more social needs of the people in its communities, like housing, That takes very different relationships with services and systems and sectors they may not have worked with before. The second is, we heard a lot about how the healthcare system is innovating and how we have to rebuild it from the bottom up, but change like that is very hard for the providers that serve the most vulnerable and low-income populations. They may not have the resources to hire differently, to build different technology and computer systems, so how do we help them make that transition? The third thing is to be at the table when someone defines what value is going to mean for patients. So yes, we want to reduce costs. Yes, we want to improve clinical outcomes. But what are the things that matter most to patients and families that we want to create incentives for? The last thing I'll say is that at the heart of everything we are doing is engaging consumer voice, raising up the voice and authority, and frankly, the power of people living in communities, people with lived experiences, as decisions are being made in the healthcare system and in government about value. And I hope we'll be able to talk more about that engagement on this panel, but I'll just finish by saying that in the Robert Wood Johnson Foundation, one of the things that we are doing is trying to rely not only on the voices of traditional experts when we make our funding decisions and when we decide how we're going to use our resources, but also engaging the voices of people with lived experience in communities because they are the true experts in these issues.
Great. It's great to be here. I want to go back to a comment that Elizabeth made around the status quo, because I think when you think about deploying resources, and particularly from a philanthropic standpoint, you really do have to ask the question, how is it really? And give yourself an honest answer. So what is the status quo? We don't have a healthcare system. We don't. We have a sick care system. It's deeply flawed. There's entrenched competitors that are profiting on the back of the American public. And it's failing us. In fact, it's literally killing us. We recently did a survey with the Gallup organization where we asked, have you recently lost a family member or a friend after they weren't able to pay for the health care that they needed? 13% of America said, yep, I've lost someone because they couldn't pay for their health care. That's over 30 million Americans. If you look at non-whites, it was 20%. We can't be complacent with that. That is absolutely intolerable. If you look at the youth in America, if you have 6 or more ACEs, adverse childhood events, your life expectancy is 20 years less than someone who doesn't. Our healthcare system, our sick care system, does nothing to address that. So when we think about the resource deployment at West Health, we're very focused on the cost of healthcare, but also evolving the delivery of healthcare so that it's more aligned with the needs of the most vulnerable among us, particularly seniors. I think the best way to illustrate how we do our work is through an example of where we've identified a problem, really shined a light on it, identified a path forward and walked that path, and then really thought about the scalability and sustainability of that model. So every day, seniors present to the emergency room, and historically, there's been very little options. You either admit the patient or you send them back to the community for ambulatory care. There's patients that don't need to be in the hospital, but we don't have the resources in the community for them to be managed at home where they want to be. There's patients that present to the emergency room with abdominal pain, and it's not because they have a mass or a trauma, it's because they're hungry. And there's these millions of missed opportunities when you look at how we historically deploy healthcare to do more with that interaction, to identify the fact that it's not a medical condition, but a state of hunger that's causing the abdominal pain, to think about deploying resources in a more longitudinal way so that we can onboard these individuals to a more comprehensive care strategy. So we stood up a geriatric emergency department in San Diego and formed a network of over 9 geriatric emergency departments across the country to study what pathways work, what pathways don't work, right? To build the data and the evidence around it. And then partnered with the American College of Emergency Physicians to establish accreditation at 3 levels nationally. And now there's over 120 geriatric emergency departments across the country, more coming on board every single day. This is just over the past 18 months. The VA is now moving to accredit their emergency departments nationally. And our policy office is thinking about how can you evolve the broader policy structure to incentivize more systems to onboard this. And from a philanthropic standpoint, this is an example of where dollars jump-started a movement. But today, more than 90% of the geriatric emergency departments coming on board are self-funded from the systems. It's simply just better, smarter care, and it needs to be done. And I think it's a great example of how there are some simple, common-sense things that we can do that really create greater value, in the system.
Excellent. Cara.
Great, thank you. And thank you for having me here. I'm delighted to be here. So you asked why value is important to us as a philanthropy and how it's important to our thinking about strategy. And my immediate kind of reaction to that is, how could it not be? Mm-hmm. Right, so if you put some basic facts on the table, as a country, we spend $3.6 trillion a year on our sick care system. And what do we get for it? Right? And the answer is clearly not enough. So we spend, our $3.6 trillion, it represents about 18% of our gross domestic product. If you compare that to other OECD countries, the average is about 8%. And in return, we get 30% more deaths from preventable illness than our OECD peers. We get 20% more deaths from treatable illness than our OECD peers. So it's not good enough. It's fundamentally not good enough. And the second thing that, for us, that's important, when you think about those dollars, those huge dollars that are flowing into our sick care system, where are they coming from? In California, the state that I live in, 70% of those dollars are your tax dollars at work. Right? I mean, just sit with that for a minute. So when you think about in the previous panel asked, how do you think about redistribution of dollars when you achieve value? And one of the answers was, it depends on who controls them. 70% of those dollars are public dollars. And when they're spent on our sick care system, that means where are they not being spent? They're not being spent on education. They're not being spent on housing. They're not being spent on the environment and tackling the climate change disaster that we're all facing. So that fundamentally is a huge driver for us in saying, in order to achieve universal coverage, and not just universal coverage, but universal care, right, as well as the factors that influence health beyond the healthcare system, you have to tackle the underlying cost that sits in the health system. And the last thing I would say is, when we talk about value, the immediate place I go to is value to whom, right? Value to the system, value to politicians, value to consumers and patients. You all know better than I do, said no patient ever, I want expensive, unnecessary, interventionist, painful care. I mean, that has never happened in the history of healthcare. For my sins, in addition to my professional history, I have a very personal history of interaction with the healthcare system. I'm a young adult cancer survivor. The first thing that happens when you're diagnosed with cancer in your 30s is you sit down with a physician and they give you a huge menu of things to do. And you're confused and you're scared, right? And never did I say, yes, I'd like a few extra doses of chemotherapy. Right? That just doesn't happen. It's the prices. Yep. It's the prices. And if we can't fix that, I don't know how we can get to the universal system of both sick and healthcare that we aspire to.
Yeah. I think a lot of us have stories, and I have to say, one of the things that gives me hope is in the policymaking realms, like in the Senate, policymakers have stories.
Absolutely.
Where their families have entered the system, and really terrible outcomes have happened. I wanted to kind of try to merge a question from the audience with a question we talked about, which is one of the things that I think really every single person in this room, I know personally, I think of my family and my Cuban heritage, and health equity is such a critical crisis in our country right now. And we know, for example, that if you're African American, you're 50% more likely to die from heart disease than your non-African American colleagues. We know that our moms and babies of color are dying at higher rates. We know we have a tremendous problem in this country where there are terrible outcomes for folks because of who they are, where they live, and the color of their skin. And so one of the questions I think that's really concerning to us is transformation is an opportunity to really rethink how we deliver health and how we get to health. But it also, as being on the inside of this a few years ago, it's also about a rush to the average and moving the average. And so by definition, if you are different, it's not just that transformation isn't going to help you, it could actually make things worse. And so the question to all of you, and really whomever wants to take it, is how can we really make sure that the transformational imperative actually addresses the disparities in our country and doesn't make things worse? And then I have a really good audience question I wanted to weave in here if you guys have thoughts, which is the social determinants frame often creates in certain audiences, it's a way where people start to think about injustice and absolving beneficiaries from the social choices or responsibility. You have this weaving of people saying, well, people should be held responsible if they have a problem with drugs or alcohol. People should be responsible. You get this real tension when you talk about social determinants that can drive people away from feeling connected to and understanding the struggles of different communities. And so I'm just wondering if you guys have thoughts both about how do we use transformation towards equity and how do we address equity in a way that brings everyone in?
But I think it's important to define equity first, right? Equity is not everybody has access to the same things. Equity is people have access to the things that they need, and that's going to be different for me versus you versus others in this room. And the only way that we get that within, within a functioning system, I think, is changing what we're paying for. You have to follow the dollars, and we need more agility, and that means you need to be able to pay for the outcomes and pay for the value that you're delivering and stop what is a toxic system of fee-for-service, which just drives activity. And when you enable providers in the system to deploy the dollars on the things that are needed to address not only the medical issues, but the social determinants and address nutrition and housing and transportation, it's then that you can start to meet people where they're at and give them what they need as an individual and prioritize what's important to them and then start to lift them. And there you can start to move averages. But you have to follow the dollars as it relates to that. And that means stripping profit out of the system and redeploying it.
Anyone else have thoughts?
Yeah, I'd love to pitch in on this one.
Okay.
So I actually don't think that a rising tide raises all the boats. I think it's factually untrue. The example I'd give from California has done a tremendous job in the last 10 years of reducing the maternal mortality rate, and it has reduced the Black maternal mortality rate along with it, and the disparity remains, and it is egregious, and it is unacceptable. And so I think I agree with you. We have to solve, the underpinnings that you're describing, align the incentives, and I think we have to name and acknowledge the structural racism that sits in our healthcare system. And until we do that, until we call it what it is and figure out how to solve it at the root, those disparities are going to persist.
Right. I do agree that the healthcare system has now gotten really good at acknowledging all the things that are going on outside its walls that are creating inequity and has not maybe done such a great job of looking inside at policies and practices and history around racism and violence and so I think that is important. I think that I like the way you started the question, which is I do think that there is a positive opportunity here as we're reshaping the system to look for opportunities to address what people need to lead healthy lives. I think a really important piece of the equation is to have consumer engagement and representation and advocacy as very important and technical details are being worked out about where the money is going to go and what is going to be paid for and delivered. I have to give a little shout out to Families Health Equity Center, which has already made policy recommendations about how when you're making all those changes in how healthcare is paid for and delivered, you need to maintain a laser focus on equity. It's not something you think about later, it's something you think about while you're just developing the solutions. And also, another example is we are working in 7 states with teams of health plans and providers and consumer advocates to design new models of care that are specifically equity focused. That is their principal purpose. So I think it takes a consciousness about the risks, an excitement about the opportunities, and the consistent engagement of consumer advocates, which is why I'm so glad this panel is, I hope, getting all of you energized on these issues.
Thanks, Anna. I would say personally, that's why I'm at Families, because I believe the solution for this is going to come from us.
Yeah.
We have to show up and demand this from the system, period. And I also want to mention the Health Equity Center and our task force. We have a tremendous leader on there, Daniel Dawes, and he actually has a book about this called The Political Determinants of Health. It's a really fascinating read about this intersection between politics and social determinants that kind of gets to this question. One other question we wanted to ask, and we really wanted to end the panel on a very uplifting note, because after all, this is about really incredible positive change, right, at the heart of it. So when you reflect on all of the value and transformation work in which each of your organizations have or are investing, what are one or two of the most exciting innovations or efforts that you think has the promise of reorienting society towards health and healthcare justice?
Well, I gave my line away because I was going to say this, getting the healthcare system to look inside its walls at racism and sexism is an area where we are putting a lot of effort, but I'll give you something else instead. So in my whole career, everybody has said that a lot of the issues about how healthcare is financed and delivered and paid for are too technical for a consumer audience. They're very detailed, they're very wonky, they're very dry, and we have got to reject that paradigm. You have got to help us reject that paradigm. And I'll give you an example. One of the biggest problems that really drives health inequity in our system is that people do not trust the healthcare system. They don't feel respected by it. They don't have good experiences in it. In fact, we know that some of what lies behind the Black maternal and infant mortality numbers is a persistent dismissal of the voice and concerns of Black mothers about their health and their baby's health. So we need better technical measures that capture the experience of mothers, and especially Black mothers, in that process that can be turned around into how we think about how we're going to pay and deliver care. We are doing some of that really technical work. We're doing it through an advocacy organization. And even though it sounds really wonky, I think that is exactly the kind of thing that we need your voice at the table for. It will make a huge difference in the outcome.
Excellent. Other thoughts?
I think there's a lot that contributes to the inequities, but certainly there's a major economic component of it, and so clearly we need to address the cost, right, that just is associated with this care. And there, I think you really do have to ask the question, like, so why are things the way they are? And this is an opportunity, I think, for everyone in this room to engage on. What drives it is how people make money. How people make money, and specifically compensation packages, drive decisions from early stage innovation on whether a promising technology can reduce the need or eliminate the need for amniocentesis, or whether it goes on to the industrial side and really has no application in health. It drives the very price that you pay for medications at the pharmacy. If you look in the year 2016, there was $8.6 billion of profit generated in the pharmaceutical sector just from price taking. Just the price increases in that year generated $8.6 billion. That's the entire earnings per share growth for the entire pharmaceutical sector. So why did that happen? Why are people taking price so quickly? It's how the executives get paid. They're paid on the growth in earnings. So whenever there's an opportunity for them to make more, that's what they're going to do. And that's on the backs of Americans, and it drives more inequity across our system. And I think that's an opportunity to engage on, to shine a light on. What are these executives making? Are the boards prepared, right? And do they have the tools to really understand what those incentive models are driving, the decisions that come from that, and the implications that it has not only from a quality of care and access to drugs, but even just to the long-term strategic viability of the entities themselves.
Yeah, excellent.
So you asked us for the hopeful thing, hopeful message. I'm not sure this is that. We're going to try. I could not leave this panel without talking about mental health. So we surveyed Californians last year and found, we surveyed about people's most acutely felt health concerns or health needs or things they were worried about. And we expected affordability to be at the top of the list, and it wasn't. Mental health was at the top of the list. So that for us was a real wake-up call, right? And it ties to value, because if you have a serious mental health condition, you're you're likely to die 20 to 30 years on average earlier of a preventable physical health condition. Right? So these folks are receiving tons of care, but they're not receiving care that addresses the whole person, that addresses them as whole human beings and looks across. And so one thing that I think we're incredibly proud of and we're digging into is working with the state of California on a conversation on how you do that, how you draw together people's physical health needs and mental health needs in a system that is very fragmented at the provider level, at the payer level, which ultimately means at the patient level. So would look to you all as consumers and patient advocates to be mindful and thoughtful about how we treat an entire person.
Yeah, that's beautiful. All right, that brings us to time. So please, a warm round of applause for these fantastic panelists. And just enormous thanks to all of you for a really terrific conversation. And I hope something that has energized you to continue to fight so that we, at the end of this movement, we end up with health for all families, period. Thank you, guys.